assessing for adequate breathing. Adequate breathing, you should be assessing for rate, rhythm, quality, and depth. So what is rate? The number of breaths per minute. Rhythm, is it regular? So is it pretty consistent, the same? Could be irregular. There's other irregular respiratory rates. As far as rhythms, could be BODS, ataxic. Those are usually associated with some type of brainstem injury. May have Cheyne-Stokes respirations. So you may have there's so many varying styles, and just to give a poor example that I'm going to try to display for you on respiratory rhythm is, so if you have somebody who's going so that rate is irregular rhythm, and that may be associated with, again, BODS. That I displayed would probably be more associated with what they call Cheyne-Stokes respiratory or Cheyne-Stokes respirations. Also looking at quality. Are they in distress from breathing in? Are they struggling to get air in? How much air they're taking in? Again, looking at depth and tidal volume. Breathing can be adequate, but if the patient is working harder to breathe, he is in respiratory distress. So, but what happens when somebody's working harder to breathe? They're using more energy. When you use more energy, you need more oxygen. And the problem is, in these conditions, there's a reason we're short of breath, and chances are it's because we needed more oxygen. So now you have to use more oxygen, trying to bring in more oxygen, of which you have problems getting, whether or not it's in the airway obstruction, anywhere, VLR, upper airway, etc. So looking at signs of adequate breathing: adequate respiratory rate, clear and equal breath sounds bilaterally. Adequate, and bilaterally means both sides. Adequate air movement heard and felt from nose and mouth. Good chest rise and fall with each ventilation. So good tidal volume. Inadequate breathing, what we're looking for is, consider this: inadequate breathing leads to hypoxia. And going back to the very first video of this series, what was hypoxia? Hypoxia is lack of oxygen or low oxygen levels in our blood. Low oxygen levels in our blood is affected at cellular perfusion, reduces ATP production, then may lead our patients into anaerobic metabolism, which then we have poor cellular metabolism. And then it affects ATP production, which then affects sodium potassium pump, then that affects a cascading effect. So we're looking for hypoxia. And we want to not just look for, we're going to try to prevent hypoxia. So if somebody has inadequate breathing, can we intervene? Can we provide artificial ventilations? And because we're going to try to keep hypoxia from occurring. If breathing is inadequate, the brain begins to die within 4 to 6 minutes without oxygen. Now, somebody could be inadequate breathing but still bringing in oxygen, but if it's not caught early and we don't intervene quickly, then yeah, if the patient goes apneic and with that much decreased oxygen intake, keep in mind the brain begins to die in 4 to 6 minutes. 4 to 6, not 46, 4 to 6. Inadequate breathing can be either respiratory failure or respiratory arrest. Respiratory failure is we have respiratory stress, we have respiratory failure, and then respiratory arrest. Respiratory arrest, the patient's not breathing at all. Respiratory distress is they're short of breath or complaints of difficulty breathing, or we see that. And then respiratory failure is they're breathing either high rate, low volume, combination of the two, but their breathing is ineffective or inefficient to sustain life. They're in respiratory failure, which means if it's not corrected, they're going to go to arrest. So figure out, if we can intervene early when they're respiratory distress, well, hopefully we can keep them from going to respiratory failure. If we get to the patient when they're in respiratory failure, then, and if we don't intervene, then they're going to go into respiratory arrest. So try to catch it early, do your assessment, catch them early, and intervene when appropriate. Patients with respiratory failure or arrest require immediate positive pressure ventilation. Again, positive pressure ventilation is a skill that you will be practiced and evaluated on. Positive pressure ventilation is a process of using a bag mask device. So in CPR class, you look at the mouth to mouth or mouth to mask breathing. In that circumstance, you're taking your breath and forcing air into their lungs. With a bag mask device, you're taking an artificial ventilatory device. It's got a reserve oxygen bag on it. You're going to squeeze the bag. That, as long as you have a good mask seal over the nose and the mouth, when you squeeze the bag, it forces air into their lungs. So that's positive pressure ventilations. So what are signs of inadequate breathing? Tachypnea or bradypnea. Tachypnea is fast breathing, bradypnea is slow breathing. Rhythm, irregular patterns, again, as ataxic, Botts, Cheyne-Stokes, Kussmaul breathing, etc. We'll say Kussmaul breathing is associated with diabetic ketoacidosis patients, but those patients are regular pattern. That's a deep, regular pattern. It's not irregular rhythm like Botts or Cheyne-Stokes would be. And also looking at quality, breath sounds are decreased or absent are signs of inadequate breathing. Depth, the depth of breathing or the depth of tidal volume is shallow or inadequate. And any of those is a reason to artificially ventilate the patient. Now, again, it's saying that if you have somebody's tachypnic, fast breathing, bradypnic, slow breathing, and outside of that range, it's a reason to artificially ventilate. Well, I would agree, but I also have to say that you have to take in assessment of your patient. If somebody's breathing at 26 times a minute because they just ran a marathon, there's no reason to ventilate them unless it's ineffective. Their tidal volume isn't there. So you got to bring in multiple things. Don't just grab the bag mask device, chasing the patient around, trying to get them to lay down so you can ventilate them. And I'm somewhat joking, but if you're having to chase your patient around to ventilate them, they don't need to be ventilated. Just keep that in mind, FYI. Also looking for abnormal worker breathing. Retractions, we're going to say is subclavicular retractions, intercostal retractions. So they're using so much energy trying to get so much air in, is basically creating a vacuum. That vacuum essentially is creating in the negative pressures, creating the vacuum in our pleural cavity or our chest is pulling in so hard that we have to start seeing retractions in between our ribs and our clavicles. Nasal flaring. So nasal flaring is when their patient's breathing and you'll see their nares kind of open up, and that's nasal flaring. Abdominal breathing. So abdominal breathing is, again, we usually don't use our abdominal muscles to breathe. That's our diaphragm and our intercostal muscles. When those become ineffective, we start using our abdominal muscles. When you start seeing somebody with abdominal muscle breathing, especially in kids, that's of concern. And diaphoresis is medically termed for sweating. May have abnormal upper airway sounds, being stridor, sonorous or snoring respirations, and gurgling. Abnormal breath sounds. So again, those are upper airway sounds: stridor, snoring, gurgling. Are abnormal breath sounds, and that's going to be the lower airway sounds: stridor, wheezing, crackles. Crackles or rales, R-A-L-E-S. It's like fluid accumulation in the lungs, and if we have fluid accumulation there, it's preventing the amount of air to make it to the villi. It's impeding gas exchange at the velar level. Silent chest. So silent chest, somebody's going through the process of ventilating. You see their chest rise, but the problem is they're not bringing any air. May be common in asthma patients or any of those with obstructed airway. So there looks like they're breathing, but you have no breath sounds noted. That's what we call silent chest. Or unequal breath sounds, Unequal breath sounds may occur from mostly trauma reasons, but there are some medical reasons that only one. Basically, you have a collapsed lung on one side. So unequal breath sounds. Looking at reduced minute volume, maybe associated with decreased tidal volume or inadequate respiratory rate. Looking at chest wall movement or chest wall injury, paradoxical chest wall movement. Paradoxical chest wall movement is, so usually all of your rib cage should spread out equally. When it does not, then that's what we call paradoxical motion. It's usually associated with rib fractures, and it's broken, and basically now we have those floating ribs that should be attached. They're now not. So when your chest expands, though, that section of ribs is actually pulled inward. When that section of ribs pulled inward, then it decreases tidal volume. Not to mention the pain associated with that. So they're going to have decreased tidal volume from the pain because it hurts to breathe in, but also have decreased tidal volume because we have impeded or vacuum or a negative pressure there. Asymmetrical chest wall movement, irregular respiratory pattern, maybe associated with head injury, strokes, toxic inhalation, etc. Rapid respiratory rate without clinical improvement in the patient's condition is signs of inadequate breathing. So that's that. We talked about how to recognize it. Now it's your turn to learn information, review the information, read the textbook, look at the other videos I have posted, and practice it. Our next skills day. Our skills day will be, our next skills will cover ventilations and let you practice ventilations. So anyway, if you have any problems with any of the material, you need clarity, any clarification on anything, please let me know. Thank you.